This is Dr. Morwani. I'm going to talk on the management of autosclerosis and congenital fixation of the stapes. Dear friends, before I start talking on today's topic, that is management of autosclerosis and fixation of stapes, that is congenital fixation of stapes, I want to thank my wife and my son. You all know the amount of time I have spent in contributing to the education of ENT in our country is all because of greatness of my wife and my son. They allowed me to be away from the home with you all. It's not only I who should be grateful, I think you all whom I taught for the last 2 decades or more should be thankful to my family members. It's an odd thing to say for a surgeon that you must thank my family, but it's a fact. The patient with autosclerosis, normally they have an integrum. Quite often the disease is bilateral and it can start on one side to start with and may go on the other side, but it's not a rule. You may have a patient with unilateral conductive loss, and remember the conductive loss is there for a few decades. This patient, if it doesn't get managed surgically, then this patient is going to get sensorineural hearing loss. And very, very rarely, patients of 60s and 70s, they may come to you with pure audiogram showing pure SN loss or SN loss of such a severity. There is no recordable hearing in high frequency like 4,000, 8,000. These patients are even patients with a worse audiogram than this. That is, there is air conduction recordable. There is no bone conduction at all, but RNA is definitely negative, and the impedance conforms, that is AS type tympanogram. These patients would normally won't get tremendously good benefit for the hearing aid. But moment you do the surgery and bring the hearing up by about 30 dB or so, then these people will be better with the hearing aid. In fact, I have operated a couple of old people who were even considered in UK for cochlear implant surgery, but as the RNA was negative, we have been able to do a surgery. And remember, some of them, even the bone conduction may improve by 5, 10, 15 dB, which you don't have to tell patient pre-operatively. About these cases, that is profoundly mixed hearing loss, I'll give you one example. About 15 years back, me and Dr. Lahiri were doing workshop in Indore, and there were 2 cases of fresh stapes and one old lady with a profound mixed loss. And when you spoke to her, you realize that she has got her speech was not, she was not understanding your speech very well, so you knew the SN loss was pretty severe. But again, her RNA was negative, so I opted to operate for that case. In fact, this lady had the stapes done from one of our junior colleague, and according to him, the hearing had improved for some time, and after a few weeks, the hearing reduced again. So when I opened this up, this patient Teflon piston was just fraction of millimeters shorter. So I had to just take out the Teflon piston and put about 0.2 or 0.3 millimeter Teflon piston longer, and the post-op result was so rewarding on the table. And Larry pointed out, "Oh, you are a very lucky surgeon. I would not dare to do a revision surgery with the mixed loss." Concept is like this: if I would have found in that patient too much of granuloma on the foot plate or on the oval window where the Teflon was going in, I would have probably given up that case. These cases you do with a guarded prognosis. Once the middle ear was clean, you saw clear-cut Teflon, I knew I'm not going towards the inner ear, I'm just picking up the Teflon which is hanging in the middle ear, so there was no risk at all in doing revision surgery. So for that, any revision surgery when you are doing, you have to be very, very careful that you are not going to do damage to the membranous labyrinth. And even if the granuloma is there, put fair amount of adrenaline soaked gel form, gradually tease out these granulomas, remove your Teflon very carefully, because at times your Teflon can be too long. First surgeon might have put Teflon too long, and while removing this you can give a damage to the inner ear. So revision surgery has to be done with a lot of, first of all, guarded prognosis and very, very cautiously, and it should be done or performed by the senior consultant rather than junior consultant. If his RNA is is negative, maybe with a prolonged history of hearing impairment without any history of ear symptom, that is discharge, pain, and so on and so forth, and this is most probably otosclerosis. As the junior residents are concerned, the otosclerosis is bilateral, normal drum, normal appearance, really negative, soft spoken person is most probably otosclerosis. The current surgery which we perform for otosclerosis is that we make a fenestra, small fenestra, in the posterior half of the foot plate and connect this with incus with various processes. This surgery was pioneered by John Shear way back in 1956. At that time, the surgery was stapedotomy, that is removal of complete stapes. Okay, and there were various processes or stores being used from the lenticular process of the incus to the foot plate area, and very early in the life ENT surgeons realized that it's not a good idea to leave the old window bare, so modification came in. For example, Shuknik used to use in late 60s or early 70s wire with a fed prosthesis. The lower end used to tie a fed around the wire in such a way that this blob of fed along with the wire went into the fenestra of the old window. So he protected the foot plate area or old window area. Then the modification came, the certain surgeons started using vein graft to protect our old window. On top of it, the prosthesis came in. With the time, the technology changed. Then they realized it is not necessary to make such a big hole in the foot plate. Why? Because certain people got SN loss soon, certain people got SN loss later, or the incidence of SN loss was reasonably high, and more than that, the patient was unsteady at times, vomiting away for days together. However, it had to do not only the side of the foot plate, window in the foot plate area, but also various technology. For example, using a suction on your foot plate area, or suction after creating a fenestra in the old window area, or the length of process is also very important. Anyway, the technology changed, and then we started doing removal of half of the posterior part of the foot plate, which is further modified by removing 1/3 of the foot plate, and now we come to the international understanding that we should be making a fenestra as small as possible. Now the size of fenestra varies with the surgeon's choice, and it is between 0.5 millimeter to 0.8 millimeter. The thickness of the prosthesis is supposed to be 0.1 millimeter lesser than the diameter of the fenestra you have made. And other thing which we all agree probably all over the world, if you are not using a vein graft to protect your foot plate, of course everybody did not use a vein graft. Some people use a pericorneum, some people use a pericosteum, and rarely people also use the fascia graft, temporal fascia graft, to protect the foot plate. The understanding is that you should not have a opening in the foot plate wider, much wider than the diameter of the prosthesis. So for example, if I make 0.6 millimeter fenestra and I'm putting 0.5 millimeter prosthesis, then the rest of the fenestra should be sealed with a loose aggregated tissue or fat. But remember, when this concept of using soft tissue came in, people had not understood this technology well. Now how much soft tissue you should be placing? You should be placing soft tissue exactly measured to the fenestra which is there beside the prosthesis going in. If you have 0.2 millimeter fenestra left or 0.1 millimeter, your soft tissue should be precisely of that size. And with the pick or needle you should place not on the periphery of the oval window, practically sitting in the oval window around the prosthesis. When this technology came in, people started putting big pieces of fat from your lobule or loose aggregated tissue. And you know what happened? This fat created adhesion band between the incus and the promontory. The incus was pulled in So the prostheses are pulled in, and these patients came either with SM loss, or severe vertigo, or tinnitus, or combination of all this. So if you are using a soft tissue, please use a small amount of soft tissue to precisely close the small hole which you can see around the prosthesis. After this, you go fish, modify the technology further. Because I agreed to make a small fenestra. You went on to tell us, no, don't make only fenestra. Make this fenestra before you remove the suprastructure. Not only that, you will put the Teflon or whatever processes you are used to using before removing the suprastructure. Why it was done? It was done to reduce the incidence of floating foot plate. By doing this, did we eliminate the incidence of floating foot plate? No, we reduced it. No, it is not always possible. Especially if the fallopian canal is covering more than half of the foot plate, or sometimes the fascial nerve is distant. Fascial nerve is distant to the extent, in few cases, covering 1/3, half, or sometimes the full, complete width of the foot plate. So it may not be possible to do this procedure as described earlier, that is making a fenestra before removing the suprastructure. So there is no harm in doing the conventional stapage surgery if other possibility doesn't exist. The technology improved further, and the floating foot plate was your surgeon, while making a hole in the foot plate or fracturing the foot plate, did not use the proper movement. You are supposed to be doing a rolling movement like this and cracking the foot plate rather than pushing this perforator or pick or needle towards the inner ear. Okay, this was the reason for causing the floating foot plate. On the other hand, sometimes the foot plate was so thick, there was no way you could have fractured it or perforated the perforator. Then in early 70s when the technology came, we had a hand bar. We used to hand bar of different diameters, 0.4 millimeter diameter, 0.6 millimeter and so on. So we used to use a hand bar, again revolving movements like this, use a hand bar to thin out the foot plate and then use the perforator or pick or perforator to make a fenestra. The technology was further modified by using a mechanical tool, that is microdrill. Not the conventional microdrill which we use for the ear surgery. This microdrill is of a lower speed. Striker microdrill, for example, the speed is 1500 revolutions per minute, and the bore point which is used is a diamond bore point, and you can get a bore point of the diameter which is choice of the surgeon. In a sense, you can get 0.4 millimeter bore point, 0.6 millimeter bore point, or 0.8 millimeter bore point. In fact, since about 5 years, I've been using a hand drill which is battery operated. It's devised by one of our colleagues from Ahmedabad, Dr. Charbar, and he gives you a choice of bore point which you want. In a sense, if you want to use 0.5 millimeter bore point, he's willing to put a 0.5 millimeter bore point. And the aim of the instrument is such is a malleable a little bit, so you can bend depending upon the direction of the canal. So the mechanical tools came in, and they're very good if your foot plate is thick, and more so is a congenital stapes. Mind you, in congenital stapes, the total ball game is different. You may not find any structures. Rarely you can have a blob of bone sitting in the area where the suprastructural stapes should be there. And you can get various kind of modification of the malformation. You can get extensively thick foot plate, you can get extensively thick cruras, you can have one crura thicker than another, and so on and so forth. So these are the hand tools which have made life comfortable, more often in advanced autosclerosis, more often in congenital stapes fixation. Then the technology has further improved, and we can use, for example, laser. Again, laser can be used for various steps of the surgery. For example, getting a fenestra, fracturing or vaporizing the cruras, vaporizing the tendon of the stapes. Remember, again, in very, very thick foot plate, you have to use mechanical tool to make the foot plate thinner and then use laser. The amount of energy required to vaporize a thick bone, if the congenital stapes is a very, very thick foot plate, may be too high, and what thermal damage this could cause to the paralymph, we are not very sure at this stage of our experience with the laser. So laser has to be used when you are done adequately thinning of the footprint. In short, you should be a versatile surgeon with versatile tools used for giving steps of the surgery in a given case of the arteriosclerosis or congenital stapes of footplate. Alright, when are you going to operate the patient of arteriosclerosis? That's a question commonly asked to me. In my hands, I prefer a patient with a minimum conductive hearing impairment of 30 dB in speech frequencies. And again, depends upon what kind of job the patient is in. If the patient is in a very, very sensitive job, where his hearing is very, very important, if he's not going to, there is certain occupation, people who are going to be pilots, people are going to armed force and things like that. Even if he has the 25 dB loss and he's very, very keen to get operated, I do not mind operating. But the general rule is I should operate with a 30 dB conductive hearing impairment. Reading has to be negative. As far as general medical condition is concerned, for example, hypertension, diabetes, is it a contraindication? No, that's not a contraindication. On the other hand, they should be always under control before you do the surgery. And today, you remember, a lot of people on blood thinners, okay? In America, a lot of people take blood thinners at the age of 50 years anyway. So, if the patient is on blood thinner, you have to stop this blood thinner for at least 3 to 5 days time. Now, the next question sometimes is asked to me, what is the right age to perform the surgery? As far as arteriosclerosis is concerned, the earliest arteriosclerosis you can get in late teens. Of course, congenital stapes can be there at any age. Again, the rule is same. You must have 30 dB loss minimum. People talk about early arteriosclerosis, Schwarz sign positive. You should not be operating patient with a Schwarz sign positive, that is, the disease is very active. Fortunately, I have never seen a patient with Schwarz sign positive. But as our seniors has told us not to operate, I suppose you should not be operating. What age you should be operating, for example? Age, see, this surgery is done in a local anesthesia. Unless we are doing a congenital stapes case with you're performing the surgery on a young person, and very, very rarely, certain females may be terrified of getting surgery done under local anesthesia. We are willing to do it under general anesthesia, but most often, as almost 99% of cases, 98% of cases, we tend to operate arteriosclerosis under local anesthesia. So age is no bar. So for patient is medically fit and he's got enough of conductive component, I'm willing to operate. What is the oldest patient I am operating? 83 years old. The whole age parameter has to be related with the medical condition of the patient in short. Coming to the congenital stapes, at what age would you be operating? As we know, even a tympanoplasty we do not want to perform below a certain age for central perforation, for example. Why? Because of episodes of URTI, upper respiratory tract infection, which can cause problem. So similarly, you should not be doing congenital stapes surgery early. But on the other hand, let's say we have a child as young as 5 years old, and he has a bilateral 60 dB conductive loss, and he has got no history of recurrent URTI. I do not mind operating even this case. Have I operated 5 years old child? Answer is no. I have operated 8-year-old child. Youngest child I operated is 8-year-old. But remember, when I am operating a younger child, I will be more cautious to protect my oval window area. I would like to put a vein graft in that case and protect it. With this patient, however small chance of getting URTI, he does have a chance of URTI. And getting a security otitis media is going to be common in this case, age group. So you have to take precaution and you have to give a clear instruction to parents. The moment your child has an upper respiratory tract infection, what medication should be given to him at that age. As I mentioned earlier, the arteriosclerotic patient should have bilateral intact and normal drop. That is true in almost 99 or 98% of cases. Remember, chronic suppurative otitis media is such a common entity in our country. So, you can have a patient with a central perforation or discharging ear with otosclerosis. You can have a patient of cholesteatoma with otosclerosis. In my hand, it has happened that I had done a so-called tympanoplasty and given a normal intake drum, and I had put in my node osculation intact and mobile, and this patient has got a worse hearing after the tympanoplasty surgery, and you go back and investigate this patient, now you realize, oh my God, this patient has AS-type tympanogram. His foot plate is fixed. Okay, so this is a rare thing. It doesn't happen very often, but you must keep at the back of the mind that you can have a otosclerosis in patient with central perforation, very rare with cholesteatoma. And similarly, as far as normal drum is concerned, is true, but as the chronic suppurative otitis media is common, similarly the secretory otitis media incidence are also common. So what happens to secretory otitis media? This patient's drum may not look normal, okay, in appearance, what we describe pearly white appearance. On the other hand, it may become thin at places, and very rarely it can be retracted. In fact, my colleague Dr. A.B. of this site has pointed out this to me very often, that whenever he sees a patient with otosclerosis, if the drum is thin and slightly retracted, he would like to reinforce this drum. And same thing I learned from him, and I do this. Of course, these cases are very few, but we see these cases from time to time. Remember, the Teflon crystal, or whatever processes we've been using for otosclerosis, it rarely gets rejected. And why doesn't it get rejected? So far, this processes is not coming in contact with the drum, it won't get rejected. Now, in case where your drum is retracted and is touching on the incus, or very close to the incus, and you put a Teflon on this incus, if drum was not touching the incus, even if a fraction of a millimeter away from it, now this Teflon will touch the drum, and this is a chance of rejection of the Teflon. So in those cases, I will reinforce the drum with what? Split thickness cartilage with perichondrium. Very thin cartilage. You do not require thick cartilage at all. You require very, very thin cartilage to reinforce this drum. Coming to the other thing about the length of the prosthesis. Length is very, very important. One warning I would like to give to my colleagues. The Indian instrument dealers, the Teflon length measures they manufacture for you, or they have a plate to tell you what the length of the Teflon pistol. Be guarded about that. What they tell you is 4.5 millimeter, need not be 4.5 millimeter, it could be 4.75 millimeter. To be very frank with you, the jig which I am using in my practice, in my private practice, where it tells me it's 4.25 millimeter, it is 4.5 millimeter. My jig is wrong. Okay? So my jig is wrong in the sense the manufacturer has given me wrong. Because my problem was, before I used to buy Teflon pistol of various length. Now I have stopped buying Teflon pistol of various length. I buy for otosclerosis surgery Teflon piston of maximum 4.5 millimeter in length. That's what I buy. So when I put in a jig in 4.5, I see it start coming out. Whereas when I put it in 4.25, I was just about flushing with it, So length of Teflon is very important, and measuring is equally important. And with the experience, a lot of surgeons need not measure it, but at my age, with all the experience, I still have a habit of measuring it and putting it. And then you must make sure that your Teflon piston is not going too much inside. Maximum Teflon piston should go into film strap, or the margin of a plate is 0.2 to 0.25 millimeters. Too much inside is bad, marginally inside is also bad. So either way you can have problem, but too much inside is going to give more problem in form of vertigo, tinnitus, or maybe SN loss in future. Remember, there are incidents of SN loss after otosclerosis after age 5 years of surgery, 10 years of surgery, 20 years of surgery, and 30 years of surgery as well. Patient has looked so well for 20, 30 years, and suddenly one day he gets SN loss. So the length of process is little longer, is dangerous. For example, if patient tells you, moment you put Teflon, boss, I'm hearing tremendously well. I can hear certain fine sounds also, which as a surgeon I'm not hearing. I'm worried about it. I would think this Teflon is fraction of a millimeter longer. I will reduce the size of Teflon. The tip I am giving you as a practitioner. Books may not talk about this. So when patient is tremendously well, the moment you insert the Teflon, be a little cautious. Hanging test you do and bending test you do to make sure the length is long enough and is not short enough on other hand.
Okay, now what is hanging test and bending test? These tests are basically meant to make sure the length of Teflon is adequate. In other words, is not too short or is not too long. So you lift the incus after you place the Teflon in position. See how much incus you have to lift to bring the Teflon to the edge of the foot plate. If it comes by a fraction of a millimeter lifting, then you know it's too short. On the other hand, if you have to lift too much of incus, then you know it's too long. And the bending test has a similar principle. Here you bend the Teflon which you already inserted roughly in the center of Teflon piston, and by a little bit bending it comes out of the foot plate. It's a bad scene, that is too short. Other than if you do bend too much and it still doesn't come out, that means it's too long. I hope you understand what I mean by hanging and bending test.
I did mention earlier why Fish modified the technology to reduce the floating foot plate. And I did say that we still get a floating foot plate. Do I get it in my hand? Yes, everybody gets it. Incidence in the case of senior surgeon will be lesser than the junior surgeon, as simple as that. Floating foot plate, books will tell you try and move it. Idea is good. So how are you supposed to move the foot plate? The end which is floating, go opposite that with a fine suction needle, that is 23-24 needle, try and press on that. So you are trying to elevate the foot plate. If cannot be elevated, take a file hook and try and elevate the foot plate by going on the margin of the foot plate and elevating it. If this procedure, you have to repeat it again and again and again, please give up. By marginally floating foot plate, you are not going to cause any harm to the patient. In fact, if the foot plate goes a little bit in, it creates a little fenestra posteriorly, and you can put your Teflon piston directly in the fenestra. If you are worried, put a vein graft, put a prosthesis in that area, or on the hand, just put a prosthesis and seal the remaining air fenestra by loose tissue that is fed, taken from the earlobe. In fact, I have learned from Dr.Murali. What he does is take a post-oral, just in the post-oral glue, he takes a millimeter or two of incision and takes a small piece of loose oral tissue. Because when I see your incision here, the girls are so fancy today. They wear half a dozen earrings at all. So I do not like to give the smallest of scar in the earlobe. This is all you learn at this stage also. Now coming to the investigations. For the postgraduate student, it is very important. As far as investigation is concerned, there are two kinds of investigation. One is for the fitness of the patient for surgery. Let's forget about those. Number two, for the diagnosis. As I said earlier, the pure tone audiometry is a very, very important thing. And remember one statement. Your tuning fork test, if you have good tuning fork, that tuning fork test finding must match the audiometry finding. If the tuning fork test shows you that it is negative and the audiologist doesn't show you conductive loss, make sure you repeat your tuning fork test, and if your tuning fork test still says that this patient has a conductive loss, send the patient back to the audiologist, same one, other audiologist with a better equipment and better soundproof room. In short, there should be conductive loss, which we all did. Second diagnostic criteria, which books will be talking about, is timpanogram. AS, Asian timpanogram, suggests your autosclerosis. Very fine, very true. And remember, every case of autosclerosis is not going to have AS type timpanogram. Okay, I would say majority of it, maybe, I don't know the exact figure, 70%, 80% may have AS type. Some will have A type. Rarely you get an AD type. I mentioned to you earlier, if this patient of autosclerosis in childhood, if he had episodes of secretory or subacute otitis media, his drum is thin. The drum is flaccid. AD is coming from the flaccid drum, not from the fixation of the foot plate. So the clinical findings is important. The impression, so sometimes let's say by AD type tympanogram is the patient has a bilateral conductive loss, and in notes of the operation I may write exploratory tympanotomy. I may not write stapedotomy, that's the only difference. But when you explore, you find what is the pathology and treat it. As far as differential diagnosis of conductive hearing impairment with intact drum is concerned, today the most popular pathology which Dr. Hugo Fish has popularized again is anterior medullary fixation. This is one of the most popular etiology he has popularized. Beside that, you get anterior medullary fixation because of tympanostosis. It may not be in middle ear, it may be in attic. It can be middle ear and attic as well. Drum may be looking normal. You can have very rarely the necrosis of the lenticular process with the margin of the long process of incus. You can have adhesive bands in the middle ear. You can have congenital middle ear cholestoma, very rare entity. You can have facial neuroma, again very rare entity. And you can have so-called cochlear conductive deafness. To be very frank, I do not understand much about cochlear conductive deafness. All other pathologies I have seen. That is anterior medullary fixation, inferior medullary fixation, necrosis of the ossicular chain, adhesion bands, congenital cholestoma, and facial neuroma. As I said earlier, otosclerosis surgery, that is stapedotomy, is performed preferably under local anesthesia. You can perform permeatively, which is what I do. Certain surgeons like to perform endorally. Very rarely I do perform postorally if the canal is very, very narrow. Maybe out of 50 or 100 cases once, I may be lesser than that, to be very frank with you. The approach is not important, but permeative gives you adequate exposure in most of the cases. Important thing is otosclerosis is surgery of both the hands. And you should have good speculum, bevel-shaped speculum according to me, that nobody should be holding your speculum. If your nurse is going to hold your speculum, then you're going to take a longer time to do the surgery. The incision, theoretically speaking, is given from 12 o'clock position to 6 o'clock position. To be very frank, I tend to give a smaller incision now. But for junior colleagues, any surgery you do, you give a wide exposure, is better for you. Today, I'll give, let's say from 7 o'clock to 12 o'clock or 5 o'clock to 12 o'clock, depending on right or left here. The midpoint is about 5 to 6 millimeter, that's at 9 o'clock or 3 o'clock. There are 5 to 6 millimeter from the annulus, and the incision curves are out. The important thing is you must keep this incision at the lowest magnification of your microscope. That is 4 or 6. Do not use a big magnification. You may not be able to judge the distance. Remember, we do not have an equipment or instrument to say that this is 5 millimeters, 6 millimeter. It is your visual impression. That is 5 millimeter, 6 millimeter. The small flap is bad and the bigger flap is worse. If you take a bigger incision, for example, let's say 8 millimeter, 9 millimeter, you're going to obliterate the part of your canal and you will find difficult to work in that area. And when you come more laterally, the skin becomes thicker and thicker and will obliterate your canal much more. So the incision has to be precise. The elevation of TM should start at the midpoint, and once you have finished the elevation and you come to the annulus, then I would like to change the magnification to higher magnification, that is 10 magnification. And make sure while elevating, you should elevate the drum at the midpoint, not superiorly. Rarely your incus can, rarely if the drum is retracted and very close to the incus, you may damage the incus. Okay? So the important thing is mobilize your tympanomedular metal flap adequately. You want to see raw window niche inferiorly, and you want to go just up to the malleus. Okay, you have to see millimeter to anterior to the incus. Why? We remove it. Teflon piston goes around the incus. So there has to be enough space between incus and the incus and the malleus for you to hook the Teflon piston properly. Moment I elevated the tympanomedular flap, I like to put a small piece of gel form soaked in adrenaline in the foot plate area. Everything you learn from somebody or other. This I learned from Dr. Vishwanathan from Coimbatore. This is a man, he always, when you put in this gel form soaked in pure adrenaline on the foot plate area, till you learn curating of external canal, till you expose the incudus complex, this gel form soaked in pure adrenaline cause a fair amount of vasoconstriction. So when you're doing a stapedotomy procedure, there's minimal bleeding, or sometimes there's no bleeding, and beside the no bleeding, your recording of the procedure becomes much better. So I would like to use a gel form over there. And other thing which I not mentioned it, how much lignocaine adrenaline do I use? What is the proportion of adrenaline when I'm doing the surgery? Of course, you use pre-mixed lignocaine with adrenaline, 1 in 200,000 or 1 in 100,000, what is available in the theater. Sometimes, I operate all over India, so what is available. But most important thing, I will add additional amount of adrenaline. Now, how much adrenaline I will add? As much as possible. If this patient is younger patient, is there no history of hypertension, is not, I call something like everybody has heard the terminology pre-diabetic patient. People have not heard the terminology called pre-hypertensive patient. Anybody elderly, anybody obese, I do not want to use too much adrenaline. How much adrenaline? 5 cc, 5 drops. 5 cc of 5 cc of 2% lignocaine with 1 in 200,000 adrenaline plus 5 drops of adrenaline. The bore of needle is important. Okay, 5 drops put to 20 number needle is different than 5 drops put to 23 number needle. So we normally use 23 number needle to use these drops. Where do I inject? To be very frank, I inject at less than 9 o'clock position in the bony external canal. And if I see the blanching occur beautifully along the complete posterior canal wall, I may not inject anymore at all. At times, if you know your blanching has not occurred superiorly or inferiorly, I can inject at 12 o'clock position, I can inject at 6 o'clock position. Important thing is you must see the blanching occurring. That's very important message. And wait for a couple of minutes before you start the surgery. Whenever you're using adrenaline, especially in this surgery, it is very important to get a bloodless feed. So certain surgeons would like to inject local, then go and wash it. We surgeons are restless community. We want to get on with our procedure. This is our problem, So either have a patient or inject before you wash it for the surgery. I would like to emphasize on the size of the needle suction canula which should be used for this procedure. For example, I do not even want to traumatize minimally the external canal wall skin. So when I'm washing the canal wall, I will use 18 number needle suction cannula. Moment I am at the annulus and enter the middle. In middle I don't mind using 20 number suction cannula. Or in dead suprastructural stapes, I use 22 number suction cannula. Moment I have made a fenestra. Remember, you're never going to suck on the fenestra directly. Even if I want to suck on the margin of the foot plate, a couple of millimeters away from the fenestra, it will be 23 or 24 number suction cannula. What is called adequate exposure? When you do a stapedotomy surgery rather, I did junior boys, you remove or curate adequate amount of bone to see the base of the pyramid. To see the base of the pyramid. As well as my age group, the senior people, the minimum you should see the complete length of the tendon and insertion of the tendon into the pyramid. And what instrument do you use to take a posterior superior overhang? Is a surgeon's choice. My first choice is curate. And remember, when you're curating, the important thing is you're giving a screwing movement. Screwing movement. Corner tympani can be damaged while curating, remember that. So be careful when you're curating. You should have sharp enough curate. The second preferred instrument in my hand is a diamond burr on angled handpiece. Diamond burr on angled handpiece. Some people still use gouge and hammer. I think it's not very important what you're using. So far you are used to particular important thing is how much you are exposed. That's just much more important than how you are curating or removing the posterior superior overhang. Coming to the cutting of tendon. Tendon should be cut as close to pyramid as possible. Absolutely flush with pyramid. Why? I do not want 1, 2 or 3 millimeter tendon hanging loose in that area. It can create adhesion bands between the promontory and the tendon, and really between the Teflon piston too. So tendon should not be lying there. Tendon has to be excised totally along with the superstructure of the stapes. Next point about incurious stapedial joint. I would like to do this procedure in a high leg deviation of 16. Why? At times I have seen some senior colleagues making a mistake and taking the head of the stapes while dislocating. There is no harm in taking the head of the stapes, especially when you're doing a stapes surgery, but it's not called for. So, in case of magnification, there is a regular ligament, the ligament around the incurious stapedial joint. Tease out that with a sharp right angle look and dislocate the joint. And finally, you dislocate the crura from its base, anterior and then posterior crura. In fact, one moment of dislocating the anterior crura dislocates both the cruras unless the posterior crura is too thick. Okay, so this procedure, as I mentioned earlier, can be done before doing stapedotomy in difficult cases where you cannot visualize the adequate foot plate. Sometimes you have very narrow foot plate. Sometimes it's because of your Fallopian canal or fascial overhanging. Very rarely we have noticed there is a very short tendon. When there's short tendon, the pyramid is placed anteriorly. Okay, when the pyramid is placed anteriorly, remember that means vertical course of fascia will be slightly anterior. In cases where the tendon is short, your fallopian canal in horizontal portion will be little towards the foot plate area. These are the things which you learn from the experience and from the section. Remember, I'm the only one in the world who must have removed more than 1,000 temporal bones. So these are the areas where you find difficult to do a stapedotomy first, so you can do conventional technique and come back to putting the processes after making a fenestra and putting the process after you've done a removal of superstructures. As far as coming to the length of the processes and the diameter, I already mentioned. In my practice, I use 0.5 millimeter Teflon piston diameter. Length varies between 4 to 4.25 most probably. In female, rule of thumb 4 millimeter. In male, 4.25 millimeter. Is it a rule? No, it's not a rule. As I said, we measured in every case and put the length of process according to particular case. How do I sure you of your clinical diagnosis? Remember, before you do the procedure, in the sense before you come to removal of superficial stapes, confirm your diagnosis. Every intake drum for the convective loss, as we mentioned earlier, need not be autosclerosis. So individually palpate each ossicle, malleus separately, incus separately, stapes separately. Remember, we said there's something like an anterior malleolar fixation. We also said there's something like fixation of incurable malleolar joint. However rare in the intake drum, but they do exist. Okay, so before you go into the procedure of stapedotomy, make sure your diagnosis right before going on. Have I opened the case thinking that it is autosclerosis and I not found autosclerosis? Answer is yes. And have I found in every case some other pathology? To be very frank, let's say the anterior malleolar fixation, I have understood of this etiology only about 18 years back. So I remember at least 4 to 5 cases, I opened it and closed it because it was not autosclerosis. I was not convinced that I should be making a fenestra on this patient's foot plate and putting a Teflon. It has happened to me. And we would talk about cochlear autosclerosis, which I have not really understood in detail as I said earlier. But messages, if your diagnosis on the table you think is not right, quit. Don't indulge in doing unnecessary fenestra. This patient you can harm more. And second thing you must remember, every time your audiologist says you have conductive loss, at times, very rarely, the finest of audiologists, finest of the equipment, or finest of audiology department can give you wrong audiogram. It's not a common thing, but it can be wrong audiogram. What is showing you conductive loss, if proper masking is done, may not be conductive loss. So I have given up at times. On the other hand, have I done a stapedotomy and patient had no improvement? Fortunately, not very often, but one case I remember where I done a stapedotomy thinking it's a conductive loss on the particular audiogram, and this patient had no improvement. And when I sent him post-operatively to some other center, he had an SN loss of the same intensity which was shown as a conductive component. And it was very difficult medical legally to prove it otherwise, So be very cautious. As I said earlier, random negative is a very important landmark or a sign for you to think it's a conductive loss. Make sure you never ever suck on the fenestra of the fenestra made in the footplate area. Make sure your Teflon is not too long. Make sure the fenestra is not too big. If fenestra is big accidentally, if the half plate is removed, covered with the vein graft. If fenestra is marginally big, seal it with the tissue. The post-op tissue or fat, whatever you fancy. These are important things for patient not to be giddy post-op. And the second question is asked to me at times, how long would you like patient to be hospitalized? Normally we send the patient home same day. The message is to the patient normally I give, and out of 40 patients, one patient may feel too giddy and then he may vomit, and if he vomits, then probably I'm going to keep him overnight, okay? And I tell the patient normally to take it very, very easy for 1 week. Are they on bed rest? No, answer is no. They're not on bed rest at all. They are allowed to move from the next day or practically on the same day. All the body movements I tell them have to be slow. For example, turning backward, go slowly. Sitting up, lying down, all the body movement in short has to be slow. For example, simple thing, some people after shower, they shake their head, while wiping themselves. This is the one message which I always give them. Or some ladies, they want to put oil and shake their head, These small things are important. We tell them, please do not do any excessive movements like this after the surgery. Are they allowed to watch TV or radio next day or the same day? Answer is yes. I allow them to watch. So far they are not misusing the acoustic trauma. I don't want somebody sitting next to the speaker, for example, or being blasted with loud music. And the other controversy comes. And when do you allow your patient to fly back? Okay? This is a controversy which I do not believe much in. If this patient of mine do not have any nasal symptom ever, and it is a regular flyer, he tells me, sir, I never get heaviness in the ears when I'm flying, I never get pain in the ears, a sense of blockage, I do not mind this patient even flying on third day post-operatively. Okay, this statement, some people may not agree with it, but this is a practical experience. I'm telling you, we allow them to fly even within 3 days post-operatively. At times the question is asked, would you ever operate patient with only hearing ear with conductive deafness and definite diagnosis of otosclerosis? My answer is yes. Now, there are certain queries to it. You will do this with a guarded prognosis, for example. See, today patient is very well literate. Most of them, they go on the internet, they find out what it is. So I start my conversation like this. The book says, I should not be operating you if you have unilateral hearing loss. But it all depends on it. Just imagine, patient has got a total deafness on one side, is that 60 dB loss at the age of, let's say, 35, 40. And with age, he's going to get a sensitive component, and then his hearing is going to get worse gradually. So my answer is yes, if the patient is willing to take his chances. I'll tell them that I can give data, incidental data, maybe 1 in 2,000 or 1 in 5,000, something like that. If you are willing to take your chances, which are willing to do a surgery for you. It's wrong to say that you never given a date here. The ideal management for every case of atherosclerosis is surgery. However old or young the patient is, whatever medical problem he has, once they are controlled, ideal management is always surgery, surgery, surgery. There is no role of hearing aid in these cases. Of course, if patient is not willing for surgery at all, the hearing aid can be given. On the other hand, if the surgeon is not trained enough to do this surgery, for time being hearing aid can be prescribed in atherosclerosis and more so in congenital stapes, which is much more difficult surgery than the atherosclerotic surgery.
In this case, we are going to show you the elevation of the drum, followed by you are seeing the complete middle ear with incus. Malleus is being mobilized, incus is being mobilized, and you can make out the stapes is fixed. And again separately the crura is mobilized to confirm the diagnosis. And then again with the perforator we are making a hole, sorry, it is a pick. We make a hole with a pick, small hole is made a pick, and with the perforator the hole is widened, and this hole can be widened depending upon what size of Teflon you want to use. Here the measurement is done after the making the hole in the footplate area. Then this is the insertion of the Teflon piston, and this Teflon piston, once you confirm that both the ends in the right area, you're going to crumple it over the incus using a crocodile forceps or crimper. And once you're finished doing this, you're going to remove the suprastructures. First you're cutting the tendon, then you're dislocating the incudostapedial joint, and then you'll be dislocating the crurus from the foot plate, and the suprastructure will be removed, and you can do the testing on the table. Before doing this, you can confirm the length of your Teflon by doing a bending test. And in this case we have done a mobilization flap, and now you can see the incus is mobile, stapes is stiff, and so is the crurus. Okay, in this case we are cutting the tendon first very close to the pyramid, then we have dislocated the incudostapedial joint and flexured the crurus, and then we have done a measurement, and with the perforator, sorry, with the pick we have done an opening, and with the perforator we are widening the hole. Now you get a different size of perforators. You see, you can have a 0.4 millimeter, 0.5 millimeter, 0.6 millimeter perforators. After that, as you could see, we had inserted the Teflon, and as a small hole around the Teflon we are putting the soft tissue to seal that area, and finally the drum will be reflected back and the canal will be packed to the gel form. The length of Teflon piston is the most important aspect of this surgery, one of the most important aspects. So we are showing you measuring rod. Now a lot of people ask us, how do you measure it? You are measuring the distance between the foot plate to the upper end of the incus. Why upper end of the incus? Because once you do a stapedotomy, you want the Teflon to go about 0.2 or 0.25 millimeter through the margin of the oval window. So that's why you are measuring from the upper end, not the midpoint of the incus. Okay, because that is the extra distance you want to keep for your hearing to be optimum. Now we are showing you how we prepare the vein graft. Vein graft is guided on the pick. The extra tissue around the vein is removed, and then the vein graft is opened up the way you can see it here, and the raw area is to be facing the oval window. The area which you have freshened is facing the oval window, and this is what you can see, the placement of vein graft. Remember, the vein graft has to be pretty large, and you are making a dimple into the vein graft to decide where the lower end of the Teflon piston will be. And again the procedure is same. You put the Teflon piston lower end of the right area, and eventually the Teflon piston will be tightened over the incus as we shown in the earlier clip, and the canal will be packed, drum will be reflected and canal will be packed with the gel form. Well, this is from my old collection. In fact, this surgery is done almost about 20 years back. You can see after exploded stapedotomy, we could see the Teflon piston lying loose on the promontory, and you can see the adhesion bands also near the around the niche. So idea is break your adhesions gently. This is what we are doing, breaking the adhesion gently. And once I have broken the adhesion, I would like to inspect the foot plate area. Now for time being, we are just seeing the Teflon lying in the one edge, upper edge of the middle ear, and the lower end is nowhere close the foot plate of the stay-piece. It's lying horizontally, as you can see. So we have maneuvered gently this Teflon piston, and we are going to remove this Teflon piston. To our surprise, this surgeon had not done any surgery, in the sense there's a still suprastructure of stay-piece is present. Now we are removing the suprastructure of the stay-piece, and after removing the suprastructure of stay-piece, the stapedotomy was performed, and in fact the hole was little bigger than my liking. And so in this case, this is about 20 years back surgery done, I used a small piece of perichondrium with the cartilage. Cartilage is very very small, it's very very thin. The cartilaginous portion is going to lie on the foot plate area, and perichondrium is spread all around, and as usual the Teflon piston is put over it and crumpled, tightened over the incus. This is a very interesting case. Here the whole facial nerve, the horizontal portion of facial nerve, was lying distant. What you are seeing, this is a carda tympani which is mobilized. The stay-piece is under it, and this is a distant facial nerve on left of your frame where suction cannula is there. In fact, we have made a small hole in the foot plate with a perforator, and eventually, as I said earlier, these holes will be widened depending upon what size of Teflon you want to use. Normally I widen up to 0.6 millimeter and use 0.5 millimeter Teflon piston. And in this situation, a lot of people like to normally go and remove the suprastructures first, but I am showing you in this clip how we have been able to insert the Teflon piston with the facial nerve lying there. Now it's very important in this situation when the facial nerve is covering half of the foot plate to put your Teflon earlier. Why? At times I have seen in past that moment I remove the suprastructure, in this case the distant facial nerve descends further downwards, okay, and you find difficult to make a hole in the foot plate. So if I can see the foot plate, half of it, as I showed you in this clip, I'll make a hole, put a Teflon, and as you can see now I'm removing the suprastructure of the stay-piece. The carda tympani is in our way, and you can always push the carda tympani back in its normal position and remove the suprastructures. The important thing is you have to confirm that both the ends are in the right place. Upper end, of course, you can see it. The lower end you want to make sure that it is in the right place, and upper end has to be tightened fairly well on the incus. On the other hand, you do not have to tighten it too well, okay. So you do a various magnification, especially for the lower end, very high magnification, and make sure your Teflon is gone inside. This is a second case of congenital ear where there was an abnormal pinna, absent canal, and ossicles were not seen in the CT scan, and we are forming the canal, and here the facial nerve was really an abnormal situation. Of course, we decompressed this facial nerve because we could not visualize any stay-piece or any suprastructures of the stay-piece, neither there was any incus. So to get to the foot plate area, we mobilized the facial nerve, which was abnormally placed, laterally placed from the vertical course through the first genu, through the second genu, and now under the facial nerve you can see the cruras lying there. This is an ill-formed, improperly formed stay-piece. There is no head of the stay-piece in it. You will be able to see once I take out the cruras out, and we had no way to visualize any structure before mobilizing the facial nerve. So we have gone posterior to facial nerve, and we are doing further drilling to visualize the footplate area better. The fascial nerve is held with a suction cannula in front, and now we are doing you can see we have made a small hole in the footplate. This hole will be widened, and once we widen the hole, we want to have a very big opening in this case, and once we widen the hole, and we have put the fascia graft in this situation, and over the fascia graft, as there is no incus at all, we are putting boomerang shaped cartilage. This is a boomerang shaped cartilage put from the footplate to the anterior annulus, and these are very thin pieces of cartilage with the perichondrium. We'll be keeping couple of them over the fascial nerve to protect the fascial nerve in case surgeon in post-op period, some other surgeon post-op period wants to remove the wax. I do not want this fascial nerve to be damaged. So a couple of pieces of cartilage will be placed over which the graft will be placed. Remember, the first cartilage is for osteoplasty, and the second cartilage is for protecting the fascial nerve. I'm going to talk on few uncommon situations in stapes surgery. One of them is perilymph gusher. I'm fortunate I never come across that in my private practice, and all of us know how to deal with them. You have to give head up position, IV mannitol, put a tissue seal, give a pressure on it, with which most often it stops. Unfortunately, it's not true all the time. These are two cases which I got from Dr. Raman, who was a decision of Trichy. How we handle the CSF leak we are going to show you in these two frames. This is a case of perilymph gusher. You can see the CSF leaking out through the stapedotomy hole. This was sealed with the help of tissue glue. Baxter company and some Reliance company gives a glue to us, and this is a glue from Baxter company. What you do is take a tissue like vein graft or perichondrium or periosteum, put a glue under it, place it on the round window area, oval window area, give a pressure with a cottonoid till the CSF leak stops. Once the CSF leak stops, you can go back and put your Teflon piston as usual. This is a frame. You can see the Teflon piston is inserted. This is the second patient. Here we are showing you this again collection from Dr. Janki Raman only. See, here he is trying to insert the Teflon piston when the gusher is going on, hoping that he'll put a Teflon piston, put the tissue around it, and gusher will stop. It did not stop. So what he is doing here, this is a wax he is putting. At this time, he did not have access to the tissue glue. Now, if you want to put a wax, the important thing is take a tissue. On top of it, you are going to put the wax. Okay, tissue can be vein graft, perichondrium, periosteum, or fascia, and put the tissue, put the bone wax on top of it, give a pressure with cottonoid, wait for 5-10 minutes, and most often this gusher should stop. And this patient, you can go back after a few weeks and remove the, first of all, you have to clear a lot of wax. You cannot leave the wax what you are showing you in the frame. You have to remove wax gradually, leave it only in the promontory area, and you can go back after 6 to 8 weeks time. You have already tissue under it. This is already within 6 to 8 weeks time your gusher will stop, and you go back and insert the Teflon, and you will be able to give a reasonably good result in these cases also. The third real situation is patent stapedial artery. Fortunately, I have not seen it again, and I have seen in one of the workshop in 1991. I was invited to Madras by Dr. Senior Kameshwar and along with Dr. Ganpati, and I was to operate a case of first stapes surgery, and then they decided that Dr. Ramdas was a senior otologist from Madras. He would like to do the stapes surgery, and I was to do advanced otological procedure. Unfortunately, in that case, there was a patent stapedial artery, and theoretically, I'll tell you how to deal with them. If you can cauterize the artery with bipolar, it's the best thing, but it's difficult to get such a small bipolars to go inside. The second best thing is put a Surgisil and seal the thing with a Surgisil. You can also cauterize this artery with a unipolar indirectly. What I mean by that, make your current as little as possible, put a ball point on the one end of the artery and give a minimal current on both the sides away from the stapes area, wherever you can see the stapedial artery, and surgery still can be put on the central area. Once you're sure the bleeding is not messed, then you go ahead with the stapedotomy. Again, if you're worried at this stage, patient can be called after a few weeks. Once you're done a cauterization, patient can be called after a few years. The stapes surgery can be done. Descent facial now is seen quite often in stapes surgery, and we do recommend stapedectomy. If you have enough space to do a fenestra, make sure that your fenestra is adequate. Make sure they have enough room for the fenestra, and put your Teflon or propellant. Don't get worried about Teflon piston touching the facial now. There is no risk of Teflon piston in contact with the facial nerve to give even paresis. So far the nerve sheath is intact, you are never going to get paresis. In fact, this patient had a surgery done 2 years before. The first surgeon must be terrified and he gave up the surgery, and we done a surgery on this patient, and this is 5 years since then that he has had no paresis at all. Now there can be worse situation than this. This is a next picture. You can see here the facial nerve is so descent and it's so descending downwards that it is covering the foot plate area completely, and you cannot see the foot plate. Can you operate these cases? Of course you can operate these cases also if you have enough expertise. What you have to do is create a fenestra, that is a cochleostomy, just few millimeter inferior to the foot plate area, and go to the regular surgery. We will be showing you the small clip. This surgery is done by my ex-resident Dr. Rahul Agarwal few months back in city of Gwalior. Okay, this is the similar case where the facial nerve is overhanging and there is no foot plate seen. This is from collection of Dr. Rahul Agarwal, who has performed this surgery about 2 months back in city of he is practicing Gwalior, and here with the hand burr he has thinned out the bone on the promontory area, and with the pick he will be making a opening into the foot plate, in the promontory area, and then he will be covering the foot plate area with the tissue and putting cartilage from the foot plate towards the incus. Well, the one question which is always asked to me by a junior ENT surgeon, when can I do my first stapes surgery? There are no rules like that when you should do stapes surgery. Important thing is, moment you are very comfortable under microscope, you have done adequate tympanoplasties, adequate mastoid surgery, and in both the surgeries you handle the suprastructural stapes and incus very nicely, and you are very sure that you can do justice to the patient, please go ahead. Some people say you may do 500 surgery, 200 surgery. To me, number is not important, because I have seen some boys after 20 surgery their hand is so stable compared to some other boys within 300 surgeries. So number is not important to me, and you should do a surgery when you are very confident. The important message to the junior boys: do not do surgery unless you feel that you are going to do justice to yourself. And the second point is, first 1 or 2 surgery you can always do with the help of with a senior person around, and if you are in trouble he can always take over. The one message which I would like to give for this we are discussing the CDL inside. What about patient with a unilateral conductive loss due to autosclerosis and opposite dead ear? Today is the days of BAHAs. You know what is BAHA? Bone anchored hearing aid. If this patient of unilateral hearing aid loss, if it's younger age group, if I can do a stapes surgery and give him a good hearing on that side, remember I can insert the BAHA on the opposite side where he's got a dead ear, and he can hear through the bone conduction on the normal side. In fact, BAHA can be used for any unilateral SN loss of any etiology, so for other ears normal. So the stapes is more required for these cases today, because I can make his normal hearing altogether. I would like to conclude my CD. We had tried to cover as many points as possible in the CD. Stapes surgery can be written in 1,000 pages also, So I cannot do a complete justice of telling you everything in such a short time in the CD, but we have put all the effort to give you as much message as possible in the CD. Thank you very much for your attention.